Hi, my name is Vinyan Nguyen, and I am presenting on tumor infiltrating therapy for melanoma. Melanoma is a type of cancer that affects melanocytes, the cells responsible for producing skin pigment. This cancer develops when exposure to sunlight, combined with genetic factors, causes these cells to grow uncontrollably. While melanoma is often associated with skin, it can also appear in mucosal membranes and hidden areas of the body. Several risk factors contribute to melanoma, including excessive sun tanning, obesity, and having a weakened immune system. Because melanoma spreads quickly and is resistant to many treatments, new therapies are needed. Current treatment options range from surgery and supportive therapies for early stage cases to immunotherapy and checkpoint inhibitors for more advanced melanoma. Since the 1980s, TIL therapy has emerged as a promising option that could become a first-line treatment for cancer patients. Dr. Steven Rosenberg pioneered TIL therapy in the 1980s. The idea was to create and develop immune cells with strong tumor-killing abilities. Once these cells were created, doctors injected them back into the patient along with a growth factor called IL-2. However, this approach had two major problems. One, the immune cells did not develop efficiently, meaning large amounts of IL-2 were needed to support them. Two, large numbers of immune cells, called LAKs, were required to produce a strong enough response. Dr. Rosenberg took a new approach. Instead of trying to create immune cells from scratch, he extracted a specific type of cell from a patient's tumor. These cells were already specialized to fight cancer, and they required much less IL-2 to function effectively. By identifying the most reactive cells, disease outcomes were improved, as seen by the increased survival rates in disease control. TIL therapy has several advantages. Large numbers of immune cells can be grown, and they can recognize a wider range of tumor-related markers. With TIL therapy, newly grown TILs are tolerant and anergic, which reduces their ability to attack host cells. The extracted cells are tested in the lab to ensure their specificity and effectiveness. These cells are also grown outside the patient's body, away from any immune-suppressing influences. Lastly, melanoma is associated with a high mutation load, so many different types of TILs can be generated. TIL therapy has shown both good and bad effects in patients. In metastatic patients, TIL therapy has increased the degree and duration of response. More patients are experiencing tumor shrinkage and disease-free status for longer periods of time. Some patients even achieve complete remission, where the cancer disappears entirely. A correlation has been identified between the mutation load and response to therapy. The more genetic mutations in a tumor, the greater the response to therapy. This is because the number of neoantigens is increased, and with more antigens, there are more targets that can be attacked by both the immune system and the infused cells. Additionally, there is a synergy which has been found between TIL therapy and other treatments, such as irradiation or cyclophosphamide. Under a combined approach, where conditioning is administered prior to the infusion of TILs, responses increase tremendously. Aside from the positive effects, TIL therapy has shown to be toxic. While the infusion of IL-2 helps immune cells multiply, it can also overstimulate the immune system, leading to side effects such as nausea, skin rashes, or diarrhea. Furthermore, IL-2 is known to regulate immune responses by controlling the development of cells like Tregs. As a result, the body's ability to fight cancer becomes reduced. So, despite the effect of IL-2 infusions, TIL therapy can lead to adverse immune responses. Now I'd like to explain how TIL therapy actually works. Doctors begin by sampling a patient's tumor and extracting immune cells directly from it. Once the cells have been extracted, they are separated and encouraged to multiply using IL-2. Only the most reactive cells will be selected. Just before these cells are brought back in, the patient undergoes a process to remove any existing immune cells, thus creating space for the new TILs. This includes the use of drugs like cyclophosphamide to reduce the recruitment of immune suppressing cells like TREGs or checkpoint inhibitors. Once the patient has been properly conditioned, the expanded cells are returned. At the same time, IL-2 is infused to support both TIL survival and function. Researchers have learned more about how TIL therapy works by studying several aspects. Firstly, researchers have looked at the genetic profiles of melanoma. From genome sequencing, biological markers have been identified. These markers denote cancer status, but they can also identify mechanisms of resistance and other non-immune related processes. Since TILs are specific to their respective antigen, they can't target all markers at once. Thus, additional agents are needed to enhance and support their effect. So, combining TILs with other treatments has optimized the therapeutic regimen. Next, there's the composition and function of TILs. Through flow cytometry, RNA sequencing, and metabolite assays, researchers have been able to identify the most reactive subsets of lymphocytes, as well as the primary effector functions of those cells. As a result, the selection of TILs has been refined. Lastly, there is the role of TIL expansion. To get a sufficient response, researchers focused on the development as well as the survival of TILs. To address proper development, different cytokines and growth factors were tested in vitro. It was concluded that IL-2 was the vital component for expansion. To address stability in vivo, researchers tested different aspects of the tissue microenvironment. They used inhibitors for BRAF and PD-L1 molecules, different regimens of lymphodeletion, including radiation and cyclophosphamide treatment, as well as different survival signals such as IL-15 and 21. Combined together, it was concluded that there's a particular microenvironment which is needed to preserve and sustain the function and stability of TILs. TIL therapy has revealed 4 key insights about melanoma. 1. From the data on diagnostic and prognostic markers, melanoma generates many neoantigens. These neoantigens are susceptible to immune surveillance and targeting. Since they are recognizable, melanoma can be considered to be highly immunogenic. 2. Melanoma can avoid immune attacks in different ways. Mutations can increase PD-L1 expression, thereby suppressing immune cell activity. Antigen-presenting cells can lose the expression of MHC molecules, thereby disrupting the process of presentation and immune recognition. Lastly, cancer cells can actually recruit immune-suppressing cells to microenvironments, and as a result, inhibits and dampens the immune response. 3. Melanoma presents distinct genetic profiles. Already, there's data showing the most common mutations that we see in genes such as TERT, CDK2, KMT2, BRAF, and NRAS. And the fourth insight that we see is that the response to therapy can be explained by differences in mutation status. Previously mentioned data shows a higher number of mutations leads to a greater response. But with a deeper analysis, it shows that there's specific mutations which can explain the influence of having a higher number of mutations. In patients with high TMB, KMT2 and PD-L1 expression were the most prevalent, whereas in low TMB patients, they showed predominantly BRAF mutations. To make TIL therapy more effective, scientists are combining it with other treatments, like PD-L1 inhibitors, to boost their effect. Scientists are also looking to optimize the production process in order to create higher quality lymphocytes, with the focus being placed on reactivity as well as producing younger, less differentiated cells. The latter is particularly important because it ensures that the cell is more able to perform all the necessary effector functions. And they'll be achieved by preserving a proper telomere length and ensuring that it doesn't become too short. Lastly, scientists are trying to modify and edit TILs in the hopes of adjusting their function and improving their precision. Prime example that we see today is the addition of chimeric antigen receptors to T cells in the hopes that it would enhance avidity. The future of TIL therapy looks promising. Advances in genetic editing, production, conditioning regimens, and molecular profiling will be combined to create personalized treatments. With greater accuracy and predictive power, clinicians should be able to address all the molecular aspects of melanoma. As of now, most research is focused on melanoma, but clinical trials are expanding to other solid tumors and cancers in the lung, cervix, and breast. These experiments are also showing positive trends in tumor reduction and recurrence-free survival. In the future, TIL therapy will become more available and effective for all types of cancer. However, despite these advances, challenges remain, particularly in the high cost of treatment. A newly approved TIL therapy called lifileucel costs nearly $500,000 per treatment, making accessibility a major concern. Moving forward, being able to scale production will help increase its availability to all individuals. In summary, TIL therapy is an exciting and evolving treatment that harnesses the body's own immune system to fight cancer. While challenges remain, ongoing research is improving its effectiveness and expanding its use beyond melanoma. Thank you.